All right, let's dive into one of the most high-stakes challenges in obstetrics, hypertensive disorders in pregnancy. This is a topic where every decision counts, and being on top of your game can literally be life-saving. So let's get right to it. And yep, you guessed it, it's high blood pressure. But we're not just talking about a number on a blood pressure cuff. This is a condition that can escalate and fast with really serious consequences for both mom and baby. So, at the very center of all this is pregnancy induced hypertension, or PIH. You can almost think of it as the first warning shot. It's defined by high blood pressure that shows up during pregnancy, but its real danger, it's the potential for it to morph into the much more severe and complex syndrome, pre-eclampsia. Okay, so the first big challenge for any clinician is decoding those warning signs. It's about looking way beyond just the blood pressure reading and learning to spot those red flags, some of which are subtle and some, well, not so subtle. These are the signs you absolutely cannot afford to miss. And these aren't just vague complaints. We're talking about severe headaches, that classic pain in the upper abdomen, seeing halos. These all scream severe disease. And from a clinical standpoint, when you see those exaggerated reflexes or clonus, those rhythmic muscle beats, your alarm bells have to be ringing. That's a sign of impending eclampsia. Now, this brings us to a really big shift in how we diagnose this. For years, we were all taught that you needed protein in the urine for a preeclampsia diagnosis. Well, that rule is out. You can now make the call based on hypertension plus any sign of maternal organ dysfunction, even if the urine dipstick is totally clean. That's a huge game changer. And this right here just shows you how tricky these conditions can be. You'd think that something as serious as HELLP syndrome would only happen with the absolute highest blood pressures, right? Well, that is a dangerous assumption. Turns out about 20% of HELLP cases happen without severe hypertension at all. That's why being vigilant is so critical. So you've identified the risk. What now? How do you respond? Well, it's time to open up the medical management toolkit. These are the interventions we use to control the situation and, most importantly, buy some critical time. The whole strategy really rests on these three essential pillars. Pillar 1, get that blood pressure under control. Pillar 2, prevent the absolute catastrophe of seizures, which is what we call eclampsia. And Pillar 3, for those high-risk patients, we need to be thinking ahead and figuring out how to reduce that risk in the first place. All right, first tool in the kit for an acute crisis, antihypertensives. Labetalol is usually our go-to, a really reliable first choice. If you have a dangerously high systolic, hydralazine is going to bring it down fast. And while nifedipine is a handy oral option, there's one massive warning. You cannot use it with magnesium sulfate. It can cause a profound drop in blood pressure. And let's be super clear about why we're doing this. It's not just about protecting the mother from a stroke, as crucial as that is. Aggressively treating that severe hypertension directly helps the baby. How? By improving blood flow, perfusion, through the placenta. That reduces the risk of fetal distress and poor growth. Okay, next tool in the kit. And this one is a biggie. We're talking about magnesium sulfate. This is our #1 drug for both preventing and treating eclamptic seizures. It is a truly life-saving intervention. But here's the catch with magnesium sulfate. You have to monitor your patient like a hawk. And the very first sign that you're getting into trouble, that you're heading towards toxicity, is the loss of deep tendon reflexes, specifically that patellar reflex. It's the clinical canary in the coal mine. And if you do see those signs of toxicity, like slurred speech or worse, respiratory depression, the response has to be immediate. You stop the infusion and you give the direct antidote, calcium gluconate. Problem, solution. It's that simple and that important. Our third tool is all about thinking ahead, prevention. For patients who have these specific high-risk profiles, starting them on low-dose aspirin is an absolute indication. Now, this isn't for every single patient, but for those with conditions like pre-existing diabetes, autoimmune diseases like lupus, or a past history of PIH, it is a key part of the plan. You know, all these management tools are fantastic for keeping mom and baby safe, but they're all essentially buying us time, because they're all leading us to one place, the only definitive cure for preeclampsia. The final call, delivery, really comes down to the clinical picture. It's a tale of two very different scenarios. For severe preeclampsia, the plan is crystal clear. You stabilize the mother, and then you expedite delivery, which often means a C-section. But with mild PIH, when the baby is at term, you have a bit more time. You can do your investigations, confirm the diagnosis, and then move towards an induction. So, as we start to wrap this up, let's really crystallize the main risks we're trying to avoid and the most important takeaways from this whole clinical challenge. We have to remember what the stakes are here. That poor placental perfusion can lead to fetal growth restriction. The disease itself can progress to eclampsia, those life-threatening seizures. And tragically, eclampsia is still a direct cause of maternal death around the world. This is exactly why getting the management right is so incredibly critical. And here's one last point, something that really connects the dots to a patient's broader health. PIH doesn't just pop up out of nowhere. It can actually be a direct complication of other issues like uncontrolled diabetes. It just highlights how important holistic antenatal care really is. And all of this leaves us with a really big question for the future, doesn't it? Since delivery is our only real cure, where should we be focusing our energy? Do we need better ways to predict who's going to get sick? More effective prevention strategies? Or do we need to refine our tools for safer management while we wait for that perfect time to deliver? It's definitely something for all of us in this field to think about.